Good evening, one and all. On behalf of Dr. Agarwal's Institute of Optometry, I extend a warm welcome to each and every one of you to the 22nd episode of Optometry Series 2.0. I'm very happy to welcome and team member, Ms. Meenakshi. Hi, Meenakshi. Thank you so much for joining today. Thank you for your support. And Anshika ma'am is unable to join today. I'd like to extend my thanks to Anshika ma'am also. And I'm very happy to welcome our moderator for the day, Ms. Agnes. Hi, Agnes ma'am.
Hello, ma'am.
Thank you so much for joining us as the moderator for the day, ma'am.
It's my pleasure.
To know more about Agnes, ma'am, I'd like to call the MC for the day, Mr. Rahman Khan, who's studying third year Bachelor's in Optometry at Dr. Agarwal's Institute of Optometry. Rahman, please introduce in detail about the moderator.
Hello everyone, I am Rahman Khan from the C18 batch. It is my great pleasure to welcome you all to today's episode of Optometry Series 2.0. We have an excellent session planned for today and we are pleased to have with us our distinguished moderator, Miss Agnes Laurie. Miss Agnes Laurio completed her bachelor's degree in optometry from Elite School of Optometry. Following her graduation, she worked for 2 years at the Sankri Nitralaya, where she gained extensive clinical exposure and hands-on experience in comprehensive patient care. Driven by her keen interest in binocular vision, Agnes Ma'am further pursued 6-month fellowship in binocular vision and vision therapy. During this period, she managed various binocular vision cases and provided vision therapy, including the management of amblyopia. Currently, Ma'am serves as assistant professor and academic coordinator at Lotus Institute of Health Sciences and Management, where she is actively involved in teaching, academic coordination, and mentoring optometry students. We are truly honored and delighted to have her with us today. Please join me in giving a warm welcome to Agnes ma'am. Now moving on to our speaker for today's session. For today's session, we have Ms. Dhivyadharshini, third year optometry undergraduate student. We are excited to listen to her presentation and gain insights from her session. Over to you, Divya.
Thank you, Rahman. Myself, Dhivyadharshini, today's present are pursuing third year BSc Optometry at Dr. Agarwal's Institute of Optometry. Muscles are broadly classified into intraocular muscles and extraocular muscles. As we know, intraocular muscles are classified into three subdivisions: sphincter pupillae, dilator pupillae, and ciliary muscles. Extraocular muscles are further classified into involuntary and voluntary muscles. Under involuntary category, we have tarsal muscles. Under voluntary, we have LPS, rectus, and oblique muscles. The four rectus muscles following by two oblique muscles. The origin of rectus muscle is from annulus of Zinn. It is made up of a connective tissue, which is anterior to the optic foramen, which forms a muscle cone. It arises from the medial part of the ring, SR from the superior part, IR from inferior part, and LR from the lateral part, which at the end of the day it forms as a V pattern, like V form. And SR and MR is slightly at the anterior plane to others due to the slope of the orbital roof, which is closely attached to the optic nerve at the origin. And this attachment is like the apex of the orbit encircling the optic foramen and medial part of superior orbital fissure. The course of rectus muscle is as follows. The insertion markings have been given below. Insertion line. MR and LR are slightly convexity towards facing towards the limbus, and SR and inferior rectus are marked convexity. It is towards the limbus and which is obliquely placed at the lateral end of insertion line and is posteriorly placed. Next we come to LPS. The origin is inferior surface of lesser wings of sphenoid. The insertion is at the anterior surface of superior tarsal and skin of upper lip. We have two divisions here, involuntary division and voluntary division. Involuntary division is actually divided into middle lamella and lower lamina. Middle lamella is inserted at the superior margin of superior tarsal. Lower lamina gets inserted at the superior conjunctival fornix. When it comes to the nerve supply, voluntary division is supplied by oculomotor, which is third nerve. Involuntary division is supplied by the sympathetic nervous system. And the action of LPS is elevation of the upper lid, In case of LPS being affected, it causes drooping of the upper eyelid, which we know the ptosis. Next we come into superior rectus. The origin of superior rectus is superior limb of annulus of Zinn. It is inserted at the sclera 7.7 mm away from the limbus. It inserts obliquely, forming an angle of 23 degrees with sagittal axis. It's also connected to the LPS. So when like LR contracts to elevate the eye, LPS will also simultaneously contracts to elevate the upper eyelid. And the blood supply of SR is being done by the lateral muscular branch of cerebral part of internal carotid artery, which is by the third nerve. Next we get into inferior rectus. And the origin of inferior rectus is the same annulus of Zinn. It gets inserted at the sclera approximately 6.8 mm from the limbus, and the function of IR is depression, extortion and adduction. And the blood supply is done by the medial muscular branch of cerebral part of internal carotid artery, and the nerve supply is from the third nerve, that is the oculomotor nerve. Next we see about medial rectus, and the origin is from the annulus of Zinn. Insertion is inserted at the sclera 5.3 mm away from the limbus, and the facial expansion on the muscle sheath, it forms a medial ligament which attaches to the medial wall of the orbit. And the blood supply is being supplied by the medial branch of muscular artery, which is a branch of cerebral part of internal carotid artery and lacrimal artery. And the nerve supply of medial rectus is being done by the oculomotor nerve. Next we get into lateral rectus. It is originated from the upper and lower limb of annulus of Zinn. It's a process of greater wing which is inserted at the sclera approximately 6.9 mm from limbus. And when we see about the function of LR is abduction, and the facial expansion from the LR muscle sheath forms a lateral ligament and attaches to the lateral wall of the orbit. And the blood supply of LR is from the lateral muscular branch of cerebral part of internal carotid artery, and the nerve supply is from the abducens nerve, which is the sixth cranial nerve. Superior oblique muscle, it's originated from the lesser wings of sphenoid, which is superior medial to the optic canal. It's a fibrocartilaginous trochlea bends. It is the only muscle which bends in a U-shaped pulley at the superior medial wall orbit. And the insertion is, it is inserted at the post and lateral quadrant of the globe. The insertion line is like a curve with concavity facing towards the trochlea, and the anterior end is inserted 17 to 19 mm behind the limbus, and the blood supply is from lateral muscular branch from ophthalmic artery, and the nerve supply is from the trochlear nerve. Next we get into inferior oblique muscle, and when it comes to the origin, it is originated from the shallow depression of orbital plate of maxilla, which is located just lateral to the lacrimal sac, and it is the only extraocular muscle that originates anteriorly in the orbit, and IO is the shortest extraocular muscle all of all. And when it comes to the insertion, it is inserted posterior inferior-lateral quadrant of sclera behind the equator. And the function of the IO is extorsion, elevation, and abduction. And the blood supply is from the medial muscular branch of ophthalmic artery. And the nerve supply is given by the inferior division of the oculomotor nerve. Next, we get into involuntary muscles, which is superior tarsal, also called as Muller muscle. It is originated from inferior part of LPS, inserted at the superior tarsal plate in upper eyelid, which is get innervated by the sympathetic nerve fibers. And the function of superior tarsal is innervation of upper eyelid. It contributes up to 2 mm lift of upper eyelid beyond what LPS does. The blood supply is from the lateral and medial part of palpebral artery, which is a branch of internal carotid artery. Next, we get into inferior tarsal muscle. Its origin is from the facial expansion of IR. Insertion, when we see it's inserted at the inferior plate in the lower eyelid, and the function is to maintain the lid tone and position in the lower eyelid. And the blood supply is done by the inferior palpebral and infraorbital artery. The nerve supply is done by the sympathetic nerve fibers. Then we are moving into the classical concepts of actions of extraocular muscle. When it comes to horizontal rectus muscle, it depends upon the eye position during contraction. When MR contracts, it creates an adduction, and LR contracts to create abduction. So muscle actions are actually limited to horizontal eye movements. Then we get into vertical rectus muscle. In vertical rectus, superior rectus muscle, it involves the function of elevation, intorsion, and adduction. The concepts are theoretically explained based upon the degree of rotation of the eyeball. When the eyeball is adducted by 23 degrees, the muscle line of pull aligns with the visual axis only for elevation. But when it is adducted by 67 degrees, it cannot able to elevate efficiently, so it intots minimal or no elevation effect is being found. This effect is due to the change in axis of rotation. Inferior rectus action is depression, extorsion, and adduction. So when it is abducted by 23 degrees, the muscle action is aligned with visual axis. It acts as a depressor. But when it is adducted by 67 degrees, it cannot able to depress effectively and with minimal or no longer depression. The obliques behind the equator forms an angle of 51 degrees with an optical axis. Next, the superior oblique. Its action is depression, intorsion, and abduction. When adducted 51 degrees, it acts only as a depressor, but when abducted 39 degrees, it acts as an intortus. Inferior oblique action is extortion, elevation, and abduction. When adducted 51 degrees, it acts only as an elevatus, but when abducted 39 degrees, it acts as only as an extortus. Next, we get into agonist, synergist, and antagonist. Agonist is nothing but the primary muscle responsible for moving the eye in specific direction. For example, like in right eye for producing abduction, the right LR muscle is an agonist, the primary muscle which makes the action. And in synergist, the muscle of the same eye that move the eye in same direction for elevation purpose, that is superior rectus and inferior oblique. Antagonist, a pair of muscles from each eye having opposite actions, that is right lateral rectus contract while right medial rectus relax. Then we get into yoke muscles. It is also called as contralateral synergist. Pair of muscle one in each eye that produce conjugate ocular movement. Then we get into the physiology of extraocular muscles, that is the sixth muscle which is responsible for controlling the entire eye movement and maintaining the BV. We have four rectus muscle and two oblique muscle. MR is for adduction, LR is for abduction, and SR is for elevation, adduction, intorsion. IR for depression, adduction, extortion. SO and IR are basically intortus and extortus, which also helps in elevation and depression. So these are the muscle actions. The laws of ocular movements. So we have Sherrington's law of reciprocal innervation, where an agonist muscle contracts, its antagonist muscle relaxes. For example, during adduction of right eye, right MR contracts, right LR relax. So its importance is like it has to be done in smooth high movements. It prevents opposing muscle contraction. Then getting into Herring's law of equal innervation. Equal and simultaneous neural impulses are sent to yoke muscles of both eye during BV movements. So, example, looking to right, right LR, left MR, both receive equal neural input. The importance of this is maintains binocular coordination, essential for conjugate eye movements. Then we have monocular eye movements, which is ductions. Adduction, the movement towards the nose. Movement away from the nose is called abduction. Upward movement is elevation. Downward movement is depression. Top of eye rotates inward, which is intorsion. Top of eye rotating outward is extorsion. So the binocular eye movements pictures have been listed. Next we get into fixed axis. Fixed axis actually describes the three axes around which the eye rotates. Horizontal axis, which is x-axis, vertical axis, which is z-axis, anterior-posterior axis, which is y-axis. And the movement are elevation and depression for z, adduction and abduction, for y-axis, the intorsion and the extorsion. Next, we get into supranuclear eye movements. It refers to the control of eye movements by centers located above the third, fourth, and sixth cranial nerve in the brain. These centers coordinate and integrate signals before actually reaching the ocular motor nuclei in the brainstem. It ensures smooth and accurate eye movements. The center, location, and function of the muscles have been given below. Next, we get into the types of supranuclear eye movements. First, saccadic eye movement, which is nothing but the rapid eye movement when shifting from one target to other. And its characteristic, it is very fast movement up to 700% per second, used for reading, scanning environment, controlled by mainly by frontal eye fields. Next we get into smooth pursuit movements, which is nothing but the tracking movement. Here the smooth and continuous movement is being done, which requires moving visual stimulus. It is controlled by parietal and occipital cortex. Next, vergence movement, disconjugate movements where eyes move in opposite directions. Like for convergence near objects, divergence distance object, controlled by midbrain vergence centers. Next, we have is vestibulo-ocular reflex, which maintains a stable vision during eye movements. For example, like it mechanism work, head movement, Then it gets into vestibular apparatus, then entering into the brainstem, then the eye movement is done in the opposite direction. Looking at an object while walking or running is the best example. Optokinetic movements, here the combination of both saccades and pursuits work out when viewing moving screens. That is, example is looking outside a moving train window. And we get into the anatomy of cranial nerves. We actually have the 12 cranial nerves, which is listed in front: olfactory, optic nerve, oculomotor, trochlear, trigeminal, abducens, facial, vestibulocochlear nerve, glossopharyngeal nerve, vagus nerve, accessory nerve, hypoglossal nerve. These are the 12 cranial nerves that are present in the brain. Cranial nerves is actually 12 pair that arises directly from the brain and the brainstem. They control sensory, motor, and autonomic functions of the head, neck, and some visceral organs. The picture can clearly explain. Olfactory nerve, which is the first cranial nerve, is a type of sensory nerve. The receptor cells in olfactory epithelium, which for present in nasal cavity. The causes receptor cells is from olfactory filaments. It passes through cerebroform plate of ethmoid bone. It reaches olfactory bulb and continues as an olfactory tract to the olfactory cortex. The function of this nerve is mainly the sense of smell. And the second nerve is optic nerve, and the type is sensory nerve. Its origin is from retinal ganglion cells, and the cause is from retina, then optic nerve, then optic canal, then chiasma, and then the tract, and later the lateral geniculate body. And the function is to give the vision. The third cranial nerve is all we know, the oculomotor nerve. It is a motor and parasympathetic in nature. The nucleus is originated from the midbrain at the level of superior colliculus, and the cause is from the interpendicular fossa, which passes through the cavernous sinus, enter the orbital fissure in the superior part, and the muscles are being supplied. Three rectus muscle, one oblique muscle, and LPS is being supplied through the third cranial nerve, and the parasympathetic supply gives to sphincter pupillae and ciliary muscle. The fourth cranial nerve is trochlear nerve. The nerve is entirely motor in nature, and the nucleus is located at the level of inferior colliculus. And the unique feature of the fourth nerve is only emerging dorsally from the brainstem. And the course is from the midbrain, then to cavernous sinus, enters orbit via the superior orbital fissure. Then the muscles have been supplied, then the superior oblique gets the innervation. Next, we get into the fifth cranial nerve, which is trigeminal nerve. It is a mixed nerve. It is originated from the pons. It has divisions. The first division is ophthalmic, which is a sensory division and passes through the superior orbital fissure. Second division is a maxillary division. It is also a sensory but passes through the foramen rotundum. The third division is mandibular, which is a mixed which passes through the foramen ovale. And the function is spatial sensation, mastication muscles. And the sixth nerve is abducens nerve. It is a motor in nature. The nucleus is originated from pons, floor of fourth ventricle. And the cause is it emerges at the pontomedullary junction, passes through cavernous sinus, enters orbit via orbital fissure. And the muscle supplied is LR muscle. The sixth cranial nerve is facial nerve, which is a mixed type. Origin is from the pons. The course it comes like pontomedullary junction, and then to the internal acoustic meatus, then to the facial canal, and exits with stylomastoid foramen. So the function is the muscles of facial expression, the taste, anterior 2 by 3 of the tongue, lacrimal and salivary glands. Vestibulocochlear nerve is the eighth cranial nerve, and the type is sensory, and origin is from the inner ear. It has division: vestibular nerve for balance and cochlear nerve for hearing. Course it passes through the internal acoustic meatus. And the ninth cranial nerve is glossopharyngeal nerve. It is a mixed type, and the origin is from the medulla, and it exits through the skull and jugular foramen. And the function is for tasting purpose, swallowing, parotid gland secretion. The 10th cranial nerve is vagus nerve. Its type is mixed, and the origin is from the medulla, and it exits to the jugular foramen. And the course is it extends to thorax and abdomen. And the function of the vagus nerve is parasympathetic control of heart, lungs, and the digestive organs. And the 11th cranial nerve is accessory nerve, which is a motor in nature, and the origin is from the upper spinal cord and medulla, and the exit through the jugular foramen, and the muscle supplied is sternocleidomastoid trapezius. And the 12th and final cranial nerve is hypoglossal nerve, which is motor in nature. It is actually originated from the medulla and gets outward, that is exit is through the hypoglossal canal. And the muscle supplied is tongue muscle. So we are gonna see about the third nerve, that is oculomotor nerve, which is entirely motor in nature, supplies all the muscles except lateral rectus and superior oblique. It also supplies intraocular muscles, namely sphincter and dilator pupillae, and the functional components is somatic efferent, general visceral efferent, general somatic efferent, which is parasympathetic, somatic. For accommodation and contraction of pupil, parasympathetic, and for somatic efferent, proprioceptive impulses from the EOM is being sent to the third component, the brain component of third nerve. Oculomotor complex, it is situated in the midbrain, which is actually at the level of superior colliculus, in the ventromedial part of the central gray matter that surrounds the cerebral aqueduct. It is a longitudinal column which is a 10 mm about the length. It extends above the level of floor of third ventricle. And the components is two motor nuclei. The one is main motor nucleus, which consists of the large multipolar neurons, and the second one is small multipolar neurons. And the modern concept of Barwick explains the dorsolateral nucleus, which is ipsilateral IR, intermediate nucleus, which is ipsilateral IO, ventromedial nucleus, which is ipsilateral MR, paramedian or scattered nucleus is contralateral SR, caudal central nucleus, bilateral levated palpebrae superioris. So the second component is the accessory motor nucleus, which is Edinger-Westphal nucleus, which is posterior to the main oculomotor nerve. It sends preganglionic parasympathetic fibers. Cranial off of the nucleus is for the light reflex, and caudal off of the nucleus is for the accommodation purpose. And the median part is fork-shaped, which is also named as the nucleus of Perlia. And the connection moves as follows, like from cerebral cortex to nuclei of 4th, 6th, and 8th cranial nerve, and to pretectal nucleus, and to vertical and torsional gaze centers, and then to the cerebellum. And the course and distribution is as follow: from fascicular part to basilar to intracavernous and intraorbital, from the cerebral cortex to pretectal nucleus, and then the Edinger-Westphal nucleus and red nucleus, and the innervations have been sent via the nerve to the internal carotid artery. The trochlear nerve, which is the fourth cranial nerve. It's the longest and thinnest of all. It is entirely motor in function. It supplies the only muscle superior oblique. It is the one and only cranial nerve to arise from the dorsal aspect of the brain. It is the only cranial nerve to cross completely on the other side, arises from the contralateral side. And the functional components of this nerve is somatic efferent and general somatic afferent. The nucleus, which is situated at the ventromedial part of the central gray matter of midbrain at the level of inferior follicles, it belongs to somatic efferent column of nuclei. And the connection of nucleus is from the cerebral cortex to the nuclei of third, sixth, and eighth nerve, and to superior colliculi, and then the vertical and torsional gaze centers, and transferred to the cerebellum. And the course and distribution of the trochlear nerve is from the fascicular part to the precavernous, which is a cavernous sinus, and enters into the intracavernous part, and then finally enters into the orbit through the intraorbital part. And the sixth cranial nerve is abducent nerve, which is small and entirely motor. It supplies only muscle, that is lateral rectus, and the functional components as seen already, like a somatic efferent and general somatic afferent. And the nucleus is lower part of the pons, which is close to the midline beneath the floor of fourth ventricle. It consists of two types of multipolar cells, small multipolar cells and large multipolar cells. And the course and distribution is from the fascicular part to the basilar part to intracavernous and intraorbital. That is from cerebral cortex to the medial longitudinal bundle and the pontine nuclei and the facial nerve and the motor nucleus of the facial nerve, and then sent the other nerves. And the connection of nucleus is from cerebral cortex, nucleus, pretectal nucleus, horizontal gaze center, and the cerebellum of the brain. Trigeminal nerve, which is a fifth cranial nerve, which is the largest cranial nerve and contains both sensory and motor fibers. It has four nucleus, which is first one is the main sensory nucleus, second the spinal nucleus, third the mesencephalic nucleus, and fourth is the motor nucleus. And the functional components is sensory component, motor component. Sensory component is general somatic efferent and connection of sensory nuclei, and motor component is branchial efferent and connections of motor nuclei. And the divisions of trigeminal nerve is as follows: ophthalmic nerve, maxillary nerve, mandibular nerve. And the picture clearly explains the divisions of trigeminal nerve. And this is a summary of the 12 cranial nerves that I have explained before. And the reference is being taken from the Anatomy and Physiology of the Eye, A.K. Kurana book. And thank you.
Thank you, Dhivyadharshini.
Thank you, ma'am.
It was a very elaborate presentation. You can stop sharing your slides. Yeah, thank you, Dhivyadharshini. Now I request the moderator Agnes ma'am to add a valuable clinical inputs, ma'am.
Thank you. So Divya, it was very good presentation, and Rahman, thank you for a smart introduction about me.
Yeah, ma'am.
So yes, dear students. So here you could see all the 12 pairs of cranial nerves. So one thing, like many students used to make a mistake in it, that we don't have 12 cranial nerves, and rather it is 12 pairs of cranial nerves. Okay. So here you could see all the cranial nerves, where it is originated and where it is. So this is the bottom view of a brain, where you can see all the parts, like the cerebrum, which is covering most of the brain, and olfactory bulb, which is responsible for the loss of smell, followed by the optic tract, medulla oblongata, spinal cord, and cerebellum. And here we have pons. So the 12 cranial nerves has specific function, as Divya said. So right from olfactory, which is responsible for smell, and where lesion occurs, it leads to anosmia, right? So the same way, the optic nerve, which is responsible for sight, and the oculomotor nerve, which is responsible for the movement. So each has specific functions, and when lesions happens in these places, the corresponding effects will be seen. So here, the red pathways corresponds to the efferent motor fibers, while the blue pathway corresponds to the afferent fibers. So many people will find difficulty, like how to keep all the 12 cranial nerves in order. So you see here, all the cranial nerves are numbered in Roman numerals from 1 to 12. And these numerals are based on the anatomical positions right from the olfactory nerve, where it is starting. So the nerves, one after the other, it is listed out from 1 to 12, and we are not supposed to change the order. So that's why how to keep all these cranial nerves in mind. So my colleague used to tell students with this mnemonic, where it says, one of our trained teachers asked for very good vada and halwa, where the first letter corresponds to each cranial nerve. So in cranial nerve, we have certain reflexes which these nerves are responsible for. So the first is corneal blink reflex. We know that cornea is very sensitive than sclera. So it is because of the nerve impulses which is carried by the trigeminal nerve. And the next one is gag reflex, where like you people can try, like if something gets into your, like close to the throat, like beneath the tongue, you will be feeling some nauseatic sensation. That is because of the glossopharyngeal nerve impulses. So this gag reflex must be present if you are normal. And if there is any lesion in 9th or 10th nerve, this reflex will be absent. So followed by the pupillary reflex, where when light enters the eye, okay, so the retina detects the light and signal travels via optic nerve, optic chiasma, optic tract, which we are aware of. But here the fibers does not send the reflex to the visual cortex, okay, rather it stops at pretectal nucleus. So that's why when you see people with cortical blindness, they'll still have this reflex, okay. So this further takes to the Edinger-Westphal nucleus, which will constrict the pupil. So here you can see the midbrain part, the cross section of the midbrain, where you should be aware of all these parts, so that when I take the nerve pathway of cranial nerve 3, 4, and 6, which are primarily working only for the eye, so it will be very easy for you when you go to the anatomical positions of all this. Right from, so here your oculomotor nerve starts. And here is the red nucleus, where it connects, like each nerve has a nucleus in our brain. So that nucleus will carry the nerve impulses. So here you can see right from the cerebral cortex, pretectal nucleus, tectobulbar fibers, and which is finally going to the medial longitudinal fasciculus. So this is the general anatomy of the cross section of the midbrain. So we'll see about the cranial third nerve. So how does the impulses is carried from the muscles to the nerves? Okay. So right from extraocular muscle. So cranial nerve 3. It is supplying almost all the muscles except lateral rectus and superior oblique, right? So here, so you could see the muscles here. From there, the nerve impulses are crossing the superior orbital fissure, and it is going to the cavernous sinus, and it is crossing the cerebral artery, and finally going to the oculomotor nucleus in periaqueductal gray matter. So again, how does it receive the impulses from the brain so that action to occur? So for example, if my superior rectus has to work, or my superior, like lateral rectus has to work. So this superior rectus, all the other muscles, how it will act once the signals are reaching the brain. So from this oculomotor nucleus, again, fascicles pass through red nucleus, as I already showed in this slide. You could see here this red nucleus, and this is called substantia nigra. So where these dopamines are produced. So from the red nucleus, it goes to the substantia nigra and exited interpedunclar fossa between this superior cerebral artery and goes to the lateral wall of the cavernous sinus. So why am I stressed about this lateral and the medial wall? Because when I take the subsequent nerve pathways, you will be able to understand why it is significant. Because here, this third nerve, it comes from the same side and it receives the impulses and goes to the same side. So the nerve impulses are sent to the muscle on the ipsilateral, which means on the same side. But except one muscle, that is superior rectus. In superior rectus, crossing happens, so it will supply the contralateral eye. For example, the nerve impulses from the right eye, it goes to the nucleus and it comes back and sends the signal to the contralateral eye. Okay, so here you could see extraocular muscles goes to the oculomotor nerve, orbital fissure, cavernous sinus, subarachnoid space, interpeduncular fossa, and it reverses. Okay, so the same way for the cranial nerve 4. So which is supplying for superior oblique. So again, here you could see the nucleus, the trochlear nucleus. So each nerve has its own nucleus, as I said before. So from the superior oblique muscle, the nerve impulses has to be sent. So it goes through the trochlear nerve, superior orbital fissure as the previous picture, subarachnoid course around midbrain, dorsal exit from brainstem. So this is the only muscle and only nerve where it exits before the brainstem. Okay, that too on the dorsal side, because here decussation occurs. So the trochlear nucleus in the midbrain. How does the reverse pathway occur? The same way, from the trochlear nucleus, fibers decussate in superior medullary velum and dorsal brainstem exit. Okay, so here this fourth cranial nerve, which is supplying for the superior oblique. So the right eye will get the nerve impulses from the left nerve, and the left eye will get the nerve impulses from the other one. So going to the sixth nerve, which is supplying for the abducens. So this abducens nerve, it goes through the superior orbital fissure, cavernous sinus, the same way which we saw in the previous nerves also. And this one, it goes to the pontomedullary junction, where the abducens nucleus is present in caudal pons. So this abducens nucleus, through that, nerve exits its pontomedullary junction, ascends into the clivus, cavernous sinus, superior orbital fissure, and finally to the lateral rectus muscle. So both this third and fourth nerve, all the impulses and nucleus were limited up to midbrain. Okay, but this is under pons, that are caudal pons. And you could see the sixth nerve nucleus in caudal pons, it is beneath the facial colliculus. So when you see the abducens nucleus, very adjacent to that, facial follicles will be there. So people may have, for example, if they have lesion in facial nerve and you want to find out whether the patient has only the sixth nerve palsy or they have combination of seventh nerve also, which is the facial nerve, you could just place the cotton, like a piece of cotton over the face, and how we used to do corneal sensitive test. The same way you can do it on the face also. And if people could face the sensation, then there is no problem or no lesion in the seventh nerve. So that way you can easily isolate the sixth nerve and seventh nerve palsies. So I have summarized here. See, you could see the superior rectus and all the muscles. So cranial nerve 3, it is happening on the same side. And sixth nerve also, it is happening on the same side. But only the superior oblique, it goes to the other side and supplies the muscle. So the cranial nerve lesions, I have highlighted here only the nerves which are responsible for the eye. So the optic nerve when lesions occurs, yes, you will have loss of pupillary contraction, and further you will be having RAPD. And oculomotor nerve, yes, dilated pupil, ptosis, and eye moves inferiorly and laterally. So trochlear, which is supplying for the superior oblique, you will have problem in adduction. And finally, abducens, you will have limitation in the lateral rectus muscle. So you'll be not able to abduct the eye. When it is involving facial nerve, like when facial nerve has a lesion, you could see the one side of the face is just drooping down. So if in case the person's face is fine, and then still they have limitation lateral rectus, and you suspect like maybe the seventh nerve is also involved, and then you can do the test, which I said prior. So when coming to this nerve palsies, like people used to adapt a posture like face turn or chin up and down position or head tilt to compensate for the diplopia which they have got because of the nerve palsies. For example, the sixth nerve, which is the horizontal muscle, lateral rectus, if it is affected or if it has a lesion, then patient will turn towards the affected sides, which means if my right eye has been affected and I used to turn by my right side, and there will be no tilt or no chin position. And fourth nerve, which is the oblique, which is supplying for the oblique, superior oblique muscle, you could see face turn sometimes, but the tilt will be on the opposite side. So this answers for the Doll's phenomena. See, when you used to tilt your left eye, like you tilt your head towards your left side, where your eyes will go towards the opposite side. This is the Doll's phenomenon. So when this, why it is not happening on the same side for the fourth nerve? Why they are tilting the head towards the opposite side? So that's why I'm telling you, like when you're just tilting your left side, your face towards the left side, your eyeball goes towards the right side, and you could see the single fusional image. But because of the trochlear anatomical position also, if it has to be in the same side, which means I am tilting towards my left side and my eyeball is also moving the left side, you cannot see the intorsion and extorsion of the muscles taking place. So, and in the third nerve palsy, you'll be, as it is supplying for various muscles, you will be having variable face turn and variable head tilt, and you could see chin up sometimes. And this was already explained by Dhivya. So, we could have direct antagonist, contralateral synergist, and contralateral antagonist for all the muscles. For example, the direct antagonist, this agonist and antagonist will talk about the muscles in the same eye. And the synergist will talk about two muscles of the same eye. Only the yoke muscles we used to talk about the muscles in the different eye where you could see the same movement. For example, if I have to see in my dextroversion, means towards my right side, I should use my lateral rectus in right eye and medial rectus in left eye to move both my eyes towards the right direction. So one thing which will help you in clinics is the concept of angle kappa. So it is nothing but the angle between visual axis and the pupillary axis. So this is not the actual tropia. You could see the first image, the patient may mimic like exotropia, and in the second image, the baby may mimic esotropia. You could see the corneal reflex. It is nasal here, and it is temporal here. Okay, but this is not the actual tropia. This is pseudotropia. So when fovea lies just temporal to the pupillary axis, when you're shining light, the cornea will produce the nasal reflex, which means the eyes is mimicking like an exotropia. And the same thing. So when this happens, we call it as positive angle kappa. And in high, for example, in high myopia, fovea lies nasal to the pupillary axis. So corneal reflex lies temporal. Okay. So this we call it as negative angle kappa. And here the summarized table of origin, insertion, and innervation of the extraocular muscles. So one thing I want to like the saccades and pursuits, which we used to check in clinics. So when Dhivya was telling like saccades, pursuits, vestibular ocular reflex, and how do we assess it? So saccades you could do very simple. Like we have an instrument, like we used to have a stick with like bright colored. Mostly we prefer like red or green or bright colored beads on the over the stick, and we have to instruct the patient to look alternatively. Like we should tell them, if I tell you red, you please look at the red one, and if I tell you to green, please look at the green one. Okay, please don't look unless and until I tell you so. So this is the instruction you have to give. You should not instruct the patient not to move their head as we instruct for the extraocular motility. Okay, so first you will be checking in the horizontal side and the vertical one in the second image as I have shown. So how do you check the pursuits? So here is a video. So you have to look for the smooth rotation of the eyes and how much refixation is taking, and whether a patient is like moving their head or moving their body to focus on the target we show. And this saccades and pursuits, like we have to assess based on the accuracy, the ability, the head movement, and the body movement of the patient. That's why the scoring is corresponds to those movements also. That's why we should not instruct the patient regarding their body movement or head movement. So for pursuits, we'll be doing twice clockwise and twice anti-clockwise minimum. And then you check for the movement, refixations, and noted everything. So how do you grade the saccades and pursuits? We have NSUCO grading. So Northern Southern University, they found a grading system for saccades and pursuits based on the ability, accuracy, and based on the head and body movements they have. For example, you see here the saccade ability. If the patient is able to complete less than, like they were not able to focus on red and green at least twice also. So that means the score is 1, which means it is very poor. And if they are able to complete 2 rounds, it's fine, it is 2. And likewise, the score increases how perfectly they do. And the refixation also calculates, right? So how many times they are refixating on the target? When I say red, they have to focus on the red. When I say green, the same way they have to focus on the green. But when I say red again, they'll go refixate and then they come back to the red target again. So all these refixations will decrease the score. And the same way the head and body movements also. If the body movements and head movements were not that fine, it is like it was very rare, then the score will be fine. Okay, you see the no movement of head score is 5, and if there is slight movement, it corresponds to score 4 and vice versa. And this is another test which is called DEM, Developmental Eye Movement Test. So this you can see the motility also and the saccadic ability of the patient. So for the test A, you'll be telling the patient to read the numbers vertically. And you have to keep a timer for 1 minute and record how much time they are taking to complete one sheet. And the same way for the test B also. For test C, you'll be telling the patient to read the numbers horizontally. So they have to track properly so that they'll be doing it correctly. But in test C, if they miss any numbers or if they're losing the track, then the score will get reduced. So these are my references. And
Thank you so much, ma'am. It was very detailedly explained, and each kind of eye movements, how to test, what kind of test that can be used. Everything was a clear picture for the students, ma'am. Thank you so much.
so I would like to discuss a case. So people will think like extraocular motility is very simple. Like we used to do a broad heads test. So it is very simple. I'll tell the patient to look from, look here, look down. I'll follow the heads pattern and look there and up. No. So we'll not even see when the patient is looking down. We'll not even like try to hold the lids and see whether there is complete movement or there is underaction or overaction. That is the point where we miss many syndromes and muscle palsies also. So it is like very simple. I'll tell you a case where I saw a patient of 7-year-old. He's a very little kid and he's a very intelligent kid also. So when he came, he had a complaint of blurred vision for distance, and that was fine. And he said he had diplopia, which was horizontal. Okay, horizontal diplopia, and that was not noted in the primary gaze. Rather, when he looks in the up gaze, he'll be able to see that diplopia, and it was not disturbing in day-to-day life, but he could sense the diplopia. And he was asking me, why am I like seeing double images when I'm looking in that gaze? And that is a very good clue for you to find the syndromes behind that. It is nothing but the case of brown sheet syndrome, which we call as Brown syndrome. So where you have adduction limitation and elevation limitation also in adduction gaze. So the same way when we did extraocular motility to see the overaction underaction, yes, he had limitation in elevation and adduction limitation in elevation also. So just with simple history and simple extraocular motility test, you could rule out many nerve palsies and diseases also. And he was adapting to the left face turn position. So these were very little clues which will like help you to diagnose in a fraction of seconds.
Thank you so much, ma'am. A case example also, the student could correlate with their academic backgrounds in this particular thing. Ma'am, from the student's perspective, we don't have any questions as of now. If we have any questions from their side, we'll post you up with the questions, ma'am.
Yeah, sure. Anyway.
Gomati, over to you now.
Thank you so much, Meenakshi and Agnes, ma'am. Thank you so much.
Thank you.
Thank you so much for moderating for the day, ma'am, and especially thank you so much for the presentation. It was very much clear and neat, ma'am. Thank you so much.
Thank you so much for the opportunity, and thank you, Rahman, for the sweet introduction also. And thank you, Anshika, ma'am.
Actually, it is the exam season, ma'am. We got the internals going on.
Okay.
So thank you so much, ma'am. We'll wind up with the session. Dear audience, thank you all for your continuous support towards Optometry series. If you like this video, give a thumbs up and share with all your friends. And the announcement for this particular week is admissions are open for fellowship and pan-India internship at Dr. Agarwal's Institute of Optometry. So if you want to apply, please check the description box. The contact number and the email ID, everything will be given in the description box. Meet you all in the next episode. Thank you so much. Bye, ma'am.